Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I'd like to discuss a very important topic. So one of the things I do almost on every shift is teaching resident, and sometimes that resident is an emergency medicine resident. And teaching emergency medicine resident can sometimes be challenging simply because, in general, the emergency medicine residency has very little pediatric experience. Oftentimes, people who sign up for emergency medicine residency are not particularly interested in kids. They're often very young, they haven't had kids of their own, and that poses a lot of challenges. That's why I wanted to bring Dr. Steven Nazario, an emergency medicine physician who's been an assistant residency director and the residency director for the emergency medicine residency in Orlando, Florida, on the show to come and talk about the challenge of teaching emergency medicine residents pediatric emergency medicine. So, Steven, thank you very, very much for coming on the show. Let me just first introduce you to the PEM Rules listeners. And I'll say that I've known Steven for over 10 years, and not only is a great doctor, he's a great person, he's a great educator. But today we're going to talk about the challenges of educating EM physicians or EM residents in pediatric emergency medicine. So we'll just start. Steven, and please correct me if I'm wrong at any point. You are originally from Brooklyn, New York. You completed your EM residency at Jacobi Medical Center, graduating in 1997. Following that, Steven served as faculty for that program for 6 years. You were an attending there. And after that, Steven moved to Orlando, Florida, where he started the residency program that I had the honor of being faculty for. And he was the assistant residency director from 2007 until for 12 years until 2019. Is that?
Yeah, I was the associate program director through 2019 November, and then I became the program director until this past July 1. So,
right,
yeah.
and I had the great honor of being faculty for that program where Steven was the director. It was great working with him, and together we worked through some challenges in educating ED residents. So welcome, Steven, to the show. How are you?
Very good. Thank you. Thank you for the invitation, Dr. Ivan. So I appreciate the offer.
Well, you're very welcome. I also forgot to mention that between just the years in Orlando, Steven was responsible for graduating about 100 residents. That's not including your time in New York, right?
Correct.
Yeah, that's a great deal of ED physicians.
Well, you and I both share a passion for education and for getting across, especially regular concepts and sort of breaking them down. I think we both cut from a similar cloth in that we like to take complex subjects and break them down. I remember vividly to this day. I remember a video that took you many hours that you showed how potassium affects the EKG QRS rhythm, and you developed a YouTube on that, and I'm still. It's so simplistic, but it gets the point across. I know it took you a long time to do that, but it's instilled in my brain. And for those learners who were in that auditorium, that's something I guess that they will always carry with them as well. But that's the kind of energy that you bring into the table that I feel likewise that I had some good mentors. I'm sure you had good mentors. We've had these conversations, and our job is to pass that along to other.
I appreciate that. That video has gone a long way. I use it in a lot of my lectures to simplify the understanding of the effects of hyperkalemia on the EKG. But thank you very much. It's on the website too. I appreciate that. Thank you. So, Steven, first question, and if you've listened to the podcast, you know from the past, the question I ask all my guests, and I'm actually really interested to know your answer. What is your definition of a good pediatric EM physician? One who does what?
So I know that as one who trained in EM, I did gravitate towards pediatrics so often that I was one of the few attendings at my initial shop who was allowed to moonlight as a pediatric emergency medicine doctor, even though I was not PEMS trained. And it's because I approached the care of children in very much a different way than a lot of my peers. Not all my peers, but I took a note from so many, because I think a lot of people who love to focus on adults because they're more comfortable in speaking in that power dynamic where you're in a position of that you have all the answers or superiority or whatever it is. And with children, you really have to change that dynamic is not going to work for children. And in children, you have at least two different things at play: the parent or caregiver and the child. And you have to earn the trust of both in a very short amount of time. And I think that was just something that I didn't run from. I actually gravitated towards. A frustration I've had is sometimes was I would see pediatric charts just sit. The adult would grab the chest painer, the ankle injury, something like that, but would leave the pediatric charts. They would sort of collect dust almost on there. And when they had when I worked in some undifferentiated EDs and there was more than one provider, but I felt like it was often sort of like I reveled in, oh, I have an opportunity to make a difference in approaching a child, knowing that I have to have a different way of working with children of different ages. I have to sort of present myself in a non-threatening manner. I have to present myself in a manner that's accepting to both the caregiver and the child, while not avoiding the child. Right, I have to get my history, usually from the person playing the role of the adult in the room, but never forgetting that there's a second very important person who's actually the patient in the room, and coming down to their level and trying to get their trust, which is not easy because I'm just a stranger, just another stranger in another room. In other rooms with adults, people know who I am, right? I say I'm a doctor. They sort of like, okay, they don't know, they have to give me information. But a child is like, who's this guy? Especially one with maybe facial hair or wearing, God forbid, a mask or having a white coat, right? So I learned to sort of lose some of the trappings. So I would discard the white coat. I would not go in with, all of that paraphernalia. And then it's also of realizing that there are different families, right? There are families that like to say the traditional families, as we can say, it's sort of like you have both parents, but you also have single parent households. You also have households where the child may be an adopted child or a child who may be in a foster care system. So I'm not sure who this caregiver is. I have to sort of quickly ascertain what is the relationship of that current caregiver who's there presenting me this child, and get to know what their role is with this patient, right? Because definitely a parent or long-term relationship in terms of adopted parent or foster mom is very different than somebody who's just a nanny or who just happens to be taking care of that child for that day, and the child is there because of something that happened, right? They have a laceration or they fell down on the playground and they broke their extremity. So I have to sort of quickly sort of get to understand that. And I just found those fascinating to me. It just sort of piqued my interest. I also think that it's in working with the children. One of my mentors was always asking me, why am I ordering things, right? Like, because in adult world, we like to just check boxes. We like to order lots of things. You see blood work, like, everybody gets an IV and blood work. And I was like, oh, wait, what are you doing? So I have to sort of know that's not how I'm approaching that. Obviously, kids are sick, but there's a difference. Sick from, okay, sick, runny nose, sick, they have a flu, sick, they don't feel well. But I'm thinking, I really want to rationalize why am I torturing this child with an IV or with blood tests, and only under really, really tough circumstances, if I'm very ambiguous, or if I'm oh no, this is something that they're so sick that they're going to be admitted to the hospital. Then only then will I start with doing procedures on them or doing phlebotomy on them. And I think to young learners, they apply the same principle, try to apply the same principles. Like, these adults are just little adults, and I'm like, no, that's adult medicine is not the same as with the little ones. And then a newborn is not the same as a toddler, is not the same as somebody in third grade, is not the same as a 16-year-old who may be sexually active, right? Those are all different versions of pediatrics. And to learn that is something that I love, because I felt like that was just another world of medicine that had to be explored, that I have to look at.
It's funny because you basically kind of described my job, my daily job, which I take for granted. I always have a parent, I always have a child, but I guess I forget that those of you who take care of mostly adults don't realize that sometimes. And yeah, that's a very, very important point. I also could not agree more with what you said lastly. It's one of my rules: less is more. In most healthy, vaccinated children in the emergency room, no less, you really don't need a whole lot beyond history and physical. It's something that and that's, we're going to get to that, but I think that's one of the challenges that I have when I teach ED residents, because they want a CBC CMP on every kid or something like that. So we'll get to that, but I certainly appreciate that answer. My second question to you, and this is why I wanted to have you on the show, Stephen, because you're such an experienced educator in the world of, I used to call it adult emergency medicine. No more, it's general emergency medicine. And this is how kind of I analyze it, and this is where I see the difficulty. So I did residency in general pediatrics. That was 3 years. Did not take care of any adults in that residency, but gained some medical experience clearly. And then when I did my fellowship, and I honestly did not know, I don't think I knew that going into that fellowship, I spent 2 months in the adult ER, pure adult ER, where I took care of adult patients. I spent 1 month in the trauma service, which was also adult patients, and then 2 weeks in the burn unit, that was all adult patients. So in my fellowship, I spent 3.5 months taking care of adults. And then I learned that when I joined your residency faculty, most residency programs spend about 1 month a year in the pediatric ER. So overall, when you finish residency in emergency medicine, you really spend 3 months in the pediatric ER. Now, I know you spent some time in the PICU and have some other experiences, but for the most part, it seems that my experience in the adult world as a fellow was almost equivalent to the pediatric experience of the general ED resident. Yet when I finish fellowship, no offense, not that I want to, but I cannot take care of adults. But those ED residents are supposed to know how to take care of a 1-day-old baby and a 99-year-old old person. So as a faculty, as a director of residency program, how do you agree with me with that kind of conflict? And how do you resolve this, or how do you tackle this as the person who's responsible for the education of those people?
Right. I encourage them. That's an excellent observation. At right now, it's currently for EM in this country, it's 5 months of PEDS experience that the residency review committee wants to have. But that's only a recent recommendation from like the last year and a half. But still, that's 5 months out of 36 months, right? That's the great majority of months you're spent doing adult or general emergency medicine. And I noticed that even in my own training when I was a resident, that a lot of my peers were ill-equipped. They didn't know how to hold children. They didn't know how to approach children. It helped that I was a young father, so like yourself, right? That helped because children weren't a strange entity to me. I have them, right? So and then to learn like vaccination schedules in my head, or to learn what's sick versus not sick, is a little easier because you'd already experimented at home, right? So you're a kid, you go, oh yeah, I remember when my son was like this, or if you had a colicky baby that you had to work with, how exhausting that is on the parent side. So validating that parent's experience. But when you're not to lay blame on the young learners who are not parents, but when you don't have that knowledge, all you have to expect is knowledge that you glean from books or from websites, and that's a poor teacher at times, right? It'll give you facts, but it won't give you sort of the know-how. How do you comport yourself, right? How do you what are the expectations, right? When you look at the milestones, we all study the same texts that talk about the Piaget development, and these developmental milestones should be this. But they don't really mean anything to you if you just memorize facts, as opposed to I walk in a room and I go, that child is 3.5 and he's very nonverbal. He's pointing at things, or he's saying minimal things, or the non-intelligible speech. And you go, that child should have a small vocabulary, but should have some understanding, unless there's a physiologic issue. Maybe they're having hearing issues, maybe they're developmentally delayed, maybe they're on the spectrum, right? Those are the thoughts that are going through my head as I'm evaluating the interplay, just watching the child interact with their caregiver or with myself. When I come in the room, do they make eye contact? Like all of that becomes simpler when you have your own children.
Sure.
When in the vacuum of not having the children, then you have to be more astute. You have to be more of that detective and pay attention to your senses as you walk in. Trying to sit down and not approach the bed, right? Unless it's a child in extremis, and then all hands are on deck. But for the most part, you're going to sort of like watch and look and see and figure out and smell and use your other senses to pick up what the child is doing. Now, that being said, it is something where the prevalence of serious disease, life-threatening disease processes in children is so much rarer, right? So I get used to seeing chest pain all day long. So I get used to, I'm admitting every 100 patients, I'm admitting these 10, I'm observing these people, I'm getting EKGs on these people. I probably have to see 500 to 1,000 sick kids before I see that one or two really, really sick kid, right? The one that makes seasoned pediatricians nervous, that gives that big pucker factor. So I have to encourage my young learners, use every opportunity. You see a pediatric patient on that board. Yes, you're not in PZD land today. Pick that patient up. Go educate yourself. Be your own best advocate and go and get into that room. Pick that patient up and say, or tell your attending, can I pick that patient up because I need to learn from peds? And the only way is by doing, not by reading it, right? Yes, your reading supports what you're going to learn, but taking care of those opportunities, take care of the kids with the runny nose and fevers, the colicky kids, the kids that are not feeding, the ones that have a simple viral syndrome that or maybe a viral exanthem. I know rash and kids who present with rash because their parent is concerned about rash, and most of the time I'm like, doesn't look life threatening, right? That's not what they want to hear. But you have to see the kids. You have to see what normal is like. So you see normal, then you see normal variants. So then when you get to see that 500th kid and you go, wow, there's a problem here. I don't know what it is, but I know that I'm going to get some other hands. And I go to say, I'll be right back. And you get the assistance. You pull your nurse, you pull your other senior partners and say, I need you in this room now. And so this way, you recognize that these are going to be the challenging cases, but it means you got to just see that many more, right? The adult world sometimes becomes very algorithmic, STEMIs, you have stroke alerts, you have trauma, has all sorts of algorithms depending on the organ system involved. PEDS, yes, has some algorithmic stuff, but for the most part, you have to get that gestalt, which is just experience of when is it normal, when is it not normal, when are they behaving normal, right? The listless child, the flopping baby, the blue baby, right? Those are very obvious cases, right? That one is the third year medical student is telling me that child is sick. I got it. Thank you. But the children may not present that way. But remember that even sick kids are still kids, right? They want to be, they want to be not, don't loom over them. Come approach them. I would get on my knees. I would start with their toes, or I'll start looking like, oh, what's this? And I'd start playing with the the monitor line or the pulse ox line, just to get their attention away. Or if there's a toy that they're acting, I'll be looking at something else, on their bed, and I sort of will slowly as they allow me to enter their world, because there's nothing worse than trying to chase a kid on the stretcher and chase him around the room. I mean, that tells you that if he can do that, he's probably not that sick. But at the same time, I have to accomplish an exam, and I don't want to terrorize the little one. And I think that that's my thought on that.
Yeah, no, those are very good points, and I think you kind of quoted maybe subconsciously one of my rules that I teach the residents and now fellows. The way to become a good physician is to see a lot of patients. When you become a resident, a senior resident, especially, like you said, reading articles or books only goes so much. You really have to see 500 kids to recognize mild asthma, in 500 moderate asthma to recognize moderate asthma, in 500 severe asthma to recognize severe asthma, and that's a lot of patients. So I agree with you. Again, something that I try to instill to the residents.
Watching your podcast grow and watching you, in your time, having worked with you, and seeing how you teach and watching how you have interacted with some of the students and other learners that we had in common. Some of these things go back and forth. So if I've been quoting you, that's an homage to.
I think it is a huge compliment. Huge compliment. Stephen, lastly, I want to ask you again, because of your experience, we see a lot of residency programs, ED residency programs popping all over the country. So I think in Florida, there used to be only 2 residencies when you started. Is that right?
There were about 5 programs that were 5 to 6 programs in Florida in 2007, and now there's 23 programs. So we're one of 23 programs in Florida.
And majority of those programs are community emergency medicine, where again the pediatric experience is quite minimal. And I wanted to ask you, given my listeners and the nature of my listeners, what advice would you have to those ED residents? And you kind of spoke a little bit about it. Starting there, again, it's not an adult ED residency, it's a general ED residency. What advice would you give them to enhance their experience? And what advice would you give to the faculty of those programs who have limited access maybe to pediatric emergency medicine to enhance the experience of the residents?
Yeah, that's again, I would say you have to be your own best advocate for your education, right? So just like if it was, their own, if it's another rare entity, you have to go and search them out, right? You have to be watching that patient board and looking for those things. So when I see, a child number pop up, I'm looking and I'm reminding my residents, hey, in case you didn't notice, there's a 12-year-old or there's a 3-year-old over here, or there's a lot of our residencies, a lot of our hospitals now have set up super track or fast track or sort of urgent center kind of pathways for the lower acuity, right? The perceived lower acuities, which maybe a lot of the pediatric cases may come in, right? Simple sprains, cuts, bruises, they bump their head, or they have a low-grade fever and they're coming in with the sniffles, right? But they come in and they get shunted to these fast track where we have nurse practitioners and PAs, and they need their, to quickly be through in and out of the department. But those are opportunities of teaching that are lost. And I would encourage both the attendings, particularly the attendings, because they're in a position to affect change, right? They're where I want you to go see room 3. I know room 3 is a PA room, or the nurse practitioner may have already seen, but I want you to go see that patient because there's something to be learned there, even if it's learning what a normal variant is, what a otherwise healthy child is, right? An opportunity to test your paradigm, so you're asking the right questions, including vaccination history, including travel history, including birth history, right? So I love when they said, "Oh, everything's normal," and I start asking them, "So this child may be 5, right? But were they a regular birth? Did they have a complicated Did the mother have a complicated pregnancy? Is the child immunized? Is the child around other sick contacts? Did the child recently go to a petting zoo? And they look at me like with this look of, where did you get all these questions from? But those are my Pete's questions, right? They come up because they're relevant to the work we do, and they fall naturally to you and I. But unless they have those experiences, and yeah. Sometimes they look at me and go, but why is that germane to this one? And I'm like, well, it may not be germane to this one, but I want to teach you that you have to ask those questions or think about those questions in each of these interactions. Because one of these children will pop up and you go, oh, they're not immunized, or they were exposed to a petting zoo, and that petting zoos are a breed or focus for E. coli, right? And those are the kind of things that are in my head, but I have to transmit that. So I think attendings would do well to do that. And as for the motivated learner to say, oh, I gotta find some of these on my own, right? But you can look at tracking boards. Thankfully, EMRs all have the same kind of system. I spend a little bit of time teaching my learners, like the students, hey, look at this board. I know that the lower acuities tend to go over here, but make friends with those PAs and nurse practitioners, because sometimes they'll bring you up and go, I have like 5 lacerations to do. Would you like to do this one on this child? And it takes a little extra time, but that's worth the experience. That's worth the time and efforts you do that, because there's different approaches. You have to learn about different, different medications you use. The days of papoosing are gone. You have to, figure out how are you going to do this. Procedural sedation. The approaches are very different in that population than they are in adults, and it's worth learning. But you have to sometimes seek those out. They come to your ED, but they may not be so obvious, or they may not come right in front of you or drop right in your lap. So sometimes you have to be a little bit self-interested to learn that. And if there are a couple of learners in the room, the one that's more eager is probably going to get that assignment. And let that be you. I was a very self-interested person, and I would be like, I know I have a whole bunch of stuff I have to do, but that interesting case just rolled through. I want it because I want to make sure that when I leave my training, I wanted to make sure I was as prepared as possible for taking care of my future patients who I have not met yet, and in particular pediatric ones.
Yeah, so I think I'm gonna. You just gave me an idea. I'm gonna add that to the rule for my learners. What I basically heard you say is check out fast track every once in a while.
Oh yeah,
right.
Oh yeah, for sure.
We think of it as the non-interesting part of our job, but it's actually quite. It could be quite a learning experience.
Yeah.
I agree. I think that's a very, very good advice. Stephen, I can't thank you enough for coming on the show. This is super, super helpful advice. Again, I think being a resident in a general ED residency and learning PEM is quite challenging. Certainly being faculty in an emergency medicine residency and teaching PEM can be challenging, like you said. So I appreciate those good advice. I think those are very, very good tips. As usual, Stephen, the tradition on the show. The guests get to choose the outro, and you made it very easy. You said you like Nirvana and you like Foo Fighters, so I guess I'm going to have to play something by Nirvana and Foo Fighters for the outro in honor of you coming on the show.
Well, thank you so much. Thank you.
Thank you, Stephen.
Ivan, thank you so much for the opportunity, and it's been a pleasure. Thank you.
I appreciate it very, very much. Thanks again for coming on the show. And that is it for today, guys. Thank you very much for listening to PEM Rules. I hope you learned from Stephen and some of his great advice. If you're an emergency medicine resident and you want to enhance your pediatric experience, Stephen had some really, really good tips and tricks. I hope you listen. Thanks again for listening to PEM Rules, checking out the website. Please check out the Facebook website where I posted a lot of educational materials, including the video that Stephen was referring to, where I try to simplify and exemplify the EKG changes that happen with hyperkalemia. I encourage you to check it out, since an emergency physician needs to know everything there is about hyperkalemia. Thanks again, guys. Have a great day. And this is, as Stephen requested, outro, first album by Foo Fighters. This is called Big Me. Hope you like it. Have a great day.